I'll now talk about basic few steps. So as I said earlier, that there must be some donor prerequisite, like healthy young donor tissue less than 70. This is common saying, but endothelial cell count must be 2,500 or more with good morphology. Scleroderm is important, and also for first few cases, if you keep your second optical quality tissue ready with your hand, you have more confidence of doing the surgery. And the pre-op preparation is like a regular preparation. Pre-op dilatation is required for, like, if you want to combine these cases, and also dilatation helps in visualizing the Desmet scoring. So recipient marking is important, so I always put a template mark, like to keep 1 millimeter on site. And nowadays, because of automated is more popular, and also the Busin glide, people give corneal incision. But I always prefer scleral tunnel because it gives less astigmatism, and normally I don't put any suture in 90% of the cases. So it should be like your manual small incision tunnel kind of thing. So you could be superior, temporal, depending upon the previous incision. So try to explore that incision if it is very early. Then you have side ports. So side ports, the length of the side port should be such, it should not cross that template mark. Otherwise, during AR and BSS exchange, you might be going into the interface, and that will actually create trouble. So it should be just within the limit of your template mark. Then this Desmet coding, if you see that if you do under dilated pupil, it is very easy to visualize because of the red reflex. And Rajesh has also introduced little bit blunt and ball type tip in the reverse Sinskey that cause less stromal damage. But if you check your reverse Sinskey always, it should not be sharp, otherwise there will be stromal damage. We don't want any interface problem. So it is very easy in Fuchs dystrophy cases, but sometimes it is very difficult to visualize. So in that case, you use trypan blue staining. So only caution is that if there is a hydrophilic, it is better not to use trypan blue, because there are reports that hydrophilic lens stains with trypan blue. It in fact percolate the hydrophilic lenses. So again, here it is very easy to scoring, and you can remove and check the integrity. Then you can always use the BSS irrigation, like if you are doing the combined procedure, and under the fluid, normally we do under sodium hyaluronate, Hilon normally we prefer, but here if under BSS you can do it. And also the AR is also required in many cases. Here it gives the best visibility, especially if you have ACI, well, you are not sure that vitreous is there or not, and you don't want to put any viscoelastic into the anterior chamber. There AR is the nice way to do this thing. So here you see that visibility is much great visibility with AR. So you can use any of the tools. Then you have to manage the anterior chamber, so AC must be very deep. You clear the pass, you remove all the viscoelastic before putting the insertion. Also cleaning sometimes you draw the clot along with your flap. And normally I use this technique, I am still using it, forceps technique, TECO. This is 60-40, so if you just do it, always it is preferred to mark an S on the stromal side. That gives you the right orientation. So you go in, and then you just push in little, so it should be free from the wound. Then you deepen the anterior chamber, and from the other end, you just deepen it. There will be the flap is just opening up, and you just put air bubble. It opens so nicely. And sometimes I also use this needle. Needle technique is also, no, it is not working. Anyway, needle technique also, I think Dr. Namrata will be sharing the needle technique, that you just use 30 gauge needle, you just widen your incision site, put Hilon on it, just place the thing. Some people use sheet glides and some people without sheet glides. I have seen a lot of US people are doing without sheet glides and just pushed in and your thing has been done. Then after 10 to 15 minutes, you just exchange the air with BSS and your job is done. Ask the patient for keep quiet, supine position for 4 to 6 hours and you see the things are happening. So air bubble should be such that it should, I always put a drop of atropine at this point so that there should not be any pupillary block. Thank you very much.